16-year-old female volleyball player with 2-year history of intermittent anterior knee pain and swelling comes to your clinic with a prescription of left PFPS.
Patellofemoral pain syndrome.
She complains of knee giving out during aggressive sports-related movements. Currently, her pain is 8 out of 10, but she knows that the pain will decrease with a few days' rest. Her goal is to return to volleyball symptom-free. The sport-specific movements that increase pain and swelling include running, cutting, jumping, and pivoting. The medical doctor asks you to try conservative treatment before surgery is considered.
All right.
Sir.
Then we were right about.
Females more than males.
Females more than males.
Oh, I was wrong.
In your slides.
Females more than males.
It's in the slides.
In the slides.
It's in the slides.
All right, females more than males.
It
The patient will complain of what type of pain when performing what type of non-sports related movements.
Diffuse anterior knee pain
Yeah,
when performing up and down, when going up and down stairs, squats,
thing
or
is
prolonged sitting.
very good. What are the possible anatomical causes of said diagnosis?
Patellar instability and patellar dysplasia. Joint dysplasia.
Well, yes.
So patellar instability is when the patella is moving laterally instead of going to the trochlear groove, and dysplasia is when the lateral facet or facet of the patella is not optimal
Not
height.
facet.
Facetti.
It's not facet. It's the.
Face it.
It's the no. It's
Face
the,
it.
the trochlear groove.
Oh.
Is it called facet or condyle?
I have that.
But yeah.
All right, facet. Anyway.
Yeah.
So if here is the, right? If here is the two facets, the trochlear groove, it is one is lower than the other, and therefore the patella keeps on popping out. But this patient doesn't have that because conservative treatment was decided first. So obviously there are issues with soft tissue and muscle, right? Okay, manual muscle testing. Again, you have to know how to do manual muscle testing. You have to know how to do goniometry. We're not going over it today because it's for review from kinesiology. What is weak?
So the hip extensors, external rotators, and the adductors.
Very good. What else?
Oh, the core.
Core is weak. Very good. So how would you test the patient's core?
So we have the patient on the bed. We're gonna do you're gonna cross your arms, and you're just gonna come up.
That's one of the fancy ones that that we taught you.
We can also use
The single. That's a good one. Fine.
We learned this in kinesiology.
Yeah, and let me see. What's the other one? The single leg. Single leg bridge. I like that one too. So single leg bridge. Go up. Cross your arms across your arms. And if the patient moves medial laterally too much, or the pelvis drops too much after 23 seconds, that is a positive sign of weakness. Good. Range of motion. What specific range of motion is limited?
terminal knee extension.
Yes, and again, you have to know how to do goniometry. Terminal knee extension. Very good. Active testing. Show us 3 closed chain active movements that will display the weakness findings described in the above section.
Alright, so first we can do a single leg squat on the involved leg.
So if the patient has is weakness, what are you going to see?
The knee valgus, the internal rotation.
Valgus, hip internal rotation, and
femoral IR.
yeah, and
Foot pronation.
flattening of the foot. Very good. That's one. What's another one?
Standing Trendelenburg. So
Patient stands and you look. So if that happens, what side is weak? Let's see it again. They drop to the left. What side is weak?
Face
Why you?
Oh
Look
my
at
God,
me.
where are you going?
Other way. Yes.
If they drop to the left, what side is weak?
Right.
The
The
right.
right side is weak. And finally,
Turned every
step
way.
down
the step down test. There is the step.
here you go.
So we have the patient go up there. They stand on the affected foot. Go on the side. Right there. And they come down super slow. And then if they have that internal rotation, valgus, and flattening of the foot, that's a sign of the miserable malalignment
Yes.
and the weakness. Very good. We went over what the deviations would be. What mechanism might cause the above range of motion deficit?
The screw home mechanism.
The screw home mechanism. What is a brief description of the screw home mechanism?
So when going from flexion to extension at about 20 to 0 degrees
Yeah.
of extension, the tib is going to rotate it's gonna move. It's gonna start gliding on the medial condyle, and that's gonna cause the tibial external or
Right, so
lateral.
it's tibial external rotation, because the medial condyle is a little bit bigger, so when you go into extension, the tibia externally rotates. Everybody got that?
Laterally. This is here laterally rotates.
So
Carlos?
on the boards, not that I teach to the boards, you will see either external rotation or lateral rotation, because external rotation is lateral, right? Same thing with the shoulder, you might see external rotation instead of, or medial rotation instead of internal rotation.
Yeah, okay.
In the real world, I personally, I don't know if Carlos will comment, I never use lateral or medial rotation. I do internal or external rotation, both of the hip and the knee and the shoulder. Okay, very good. Now, patellar tracking you have to know, but the previous group showed us a great way to do it. So you must know how to patellar track actively and passively, including patient positioning and understanding what's going on. Special test to rule in the diagnosis. Pick one special test and how to perform it.
The Clark's test.
Clark's test. Where's your patient? There's your patient.
Here's the patient.
Hello, Clark.
Oh my, get her a step.
Someone help her.
Give her a boost.
1, 2, 3, go cat.
Whoa.
That poor back. That poor back.
All right, so the patient
This
is lying
supine.
supine, as we see in the perfect. The patient is supine. Go on.
The web space on my hand is gonna go on the superior border of the patella.
Yes, so the web space. Pick up that. There you go. Yeah.
Sorry.
And we're asking the patient to do what?
Contract the quads.
Contract the quads.
Hoot.
And the anatomical web space stops it, shoves it into the trochlear groove. If there's inflammation, there'll be pain. Carlos does not like this test because everyone has a positive sign. But Carlos, I already know. I'm just throwing the special test in there, okay? What I do is I compare both sides. If the affected side hurts more, if the affected side hurts more, then that's a positive sign. Does that make sense?
The classic comparison, yes.
Yes, you have to compare.
Yes,
Good.
sir.
Now, let's talk about the plan of care. So, on the table against gravity, phase 1, supine hip extension. Wow, I just basically told you what I wanted. All right.
Whole time. We're gonna do bridges.
Supine hip extension.
Supine
Oh,
hip
my bad.
extension.
Supine hip extension. That's a bridge.
Yeah.
Well, maybe I'm glad I wrote it.
I never.
Why is my son calling me now?
Let me pick up.
On speaker.
Hello.
Hey, how you doing? What do you want?
Can't have.
Fred?
Fred?
What?
How would you not talk about Sylvester Stallone's in the Guardians of the Galaxy?
I didn't know.
He's been in since the second one.
Sorry, you're on speaker and brought my whole class.
He is.
Well, how am I supposed to? I don't watch the movies.
He's in the second one.
That's honestly the best news you could have
First of all, I don't have to like every Sylvester Stallone movie. That's not for now. I don't remember what I had for breakfast.
call. This should have been a text.
Anyway, I gotta go. I'm almost done teaching. I apologize for not telling you.
Alright, bro, you don't have time for your own son, I get it.
I do have time for you guys. All right, we'll speak to you later. All right.
Love ya.
Fred. That's
Oh.
my life. That's my life.
My God.
That was so
Holy
adorable.
crap, that was amazing.
That is the peak of this
Yes.
the
program.
All right.
whole week. The whole
No,
semester.
program.
That was
Where were we?
so
Okay. Now, sideline hip external rotation.
We're gonna do plans.
Clamshell. All right, good. Very good. And then sideline hip abduction.
So
That was good.
leg straight, slick back, and then up and down.
All right, good.
Not so much.
Whoa. Why are you
You
yelling?
never worked in a gym or anything yet?
I did.
You have a way about you. in a
Oh
good way.
yeah.
I know.
All right.
And then,
Now,
Pros and cons.
core with neutral pelvis.
so we're gonna do a plank.
Look at that form.
When I do it, it's not neutral pelvis because I'm pelvis.
Jordan's was
Yeah.
up there.
Nice one. All right. Joint moves to improve extension, grade 1 and 2. This is specific to screw home mechanism, right? Yeah.
Oh.
No?
Is that the one? No, because we have joint.
Oh, I'm sorry.
Exten-
That's next. That's next.
Extension.
Joint move to improve extension. Sorry, what's the joint move to improve extension?
That's what the knee.
My bad. Yeah, the knee. So we're doing. What are we doing on what? You don't have to do it because they have the video. If you want to improve knee extension, you are correct. I don't. There's no. You have to put a towel under the ankle.
AP.
I mean a towel under the hamstrings. All right, don't show it bad. We'll just. You'll go
Okay,
back.
this
nah,
is
you
a
know
different thing.
So you are doing a
Louise.
posterior glide of the femur on the of the femur on the tibia.
Yes, not a
Where's the graph for flexion?
Oh, that's what I'm
Wait.
saying. Then we're
You did
doing
the
this,
tibia.
right?
You mean the tibia on the femur?
No.
No. No,
Posterior glide of femur on tibia.
Femur
Yeah,
on.
because if you do
So
the tibia,
we're-
Use the
it's
towel under that.
Because
telling me.
extension does anterior, moves anteriorly in open chain. You're moving convex on concave, so you go posterior. So to improve extension, you do a posterior glide of femur on tibia to improve extension. Go back to that module in that video, yes.
Can you do tibia and femur and do like a?
Which
You
direction
can do
would you
an
have to go?
anterior glide
Anterior
of
of the
tibia,
tibia.
but the patient must be prone. I didn't teach that one, but if you wanna do it on the practical and do it right, bless us all. Or you can do the one that we showed you and bless
get
us
it right.
all. Whichever one you wanna do, but yes, you are correct. You could do it.
And if he has the knee like that, flex, can you push it back? That's not.
That's, no, you want to, that might work for, you wanna use your body weight.
Yeah.
Yes.
Interior.
Okay, ideally, there's a million ways to do
Yeah,
it.
that.
Yeah,
you have
I think you should
leverage.
take, I told you, St. Augustine has, that's it's a university, but they have these joint moves classes that you will learn 20 ways to do knee, just to do improved extension. There's 50 different ones. If you like that, take the class.
Like an actual
Can I
drink.
use it?
If you go to outpatient, of course you
In the
do.
clinic.
Yeah. All right. Now show us a specific joint mode to improve the screw home.
Yeah.
Ah, look, so the knee is flexed to 90 degrees, and yet you're on the table so that the knee doesn't kick you in the face. So you're blocking the you're
foot.
by the foot. You're by the foot.
You put your foot,
You-
your
just like-
knee
just
on
like
top of
the
his foot.
anterior
Your
broad-
foot.
Go on the
Foot
table.
here.
Get on the table. You don't want to get on the table.
She doesn't want to get on the
All
table.
right.
Get on the table.
Yeah,
Oh,
Kat, get on the
Kat.
table. And Kat puts her knee on the patient's. This way, when you do it, it doesn't hurt you. Good. Then she takes both hands and puts it in the popliteal fossa, and then she does an external rotation of the tibia on the femur. Do you see that? She's doing external rotation. Because you want to improve external rotation, you do external rotation. You got it? As a joint, you never learned this joint mode. This is a new joint mode.
Oh gosh.
You got it? It's external rotation of tibia on femur to improve the screw home mechanism, okay? And you do grades 1 and 2 because it's early on in the treatment. Very good. Now, late phase. Show me, so for the hip extension, what are you doing late phase 1?
So you sat here, single leg, and I just wrote bridge.
A single leg bridge.
Bridge.
You're going from a double leg to a single leg bridge. I love it. What about, and the external rotation, you did clamshells, but now you're adding a
With a
TheraBand.
band.
Very good.
Band.
And then the abduction, the same one you showed us, but now you're adding a cuff weight. I love it. How about the more advanced core exercise?
So for core, we're gonna do planks on hands.
So a high plank
Yeah.
as opposed to a low plank.
Mhm.
All right. The joint mobs to improve extension are the same,
Same
just
thing,
more
yeah,
aggressive.
bend.
And the joint mob to improve screw home is the same, just now 3s and 4s. Now, phase 2. When is the patient ready for phase 2?
Oh, when they're 3 plus out of 5.
Yes, when they're improving strength. Now, show us how to strengthen this is all in standing now.
Yeah.
How do we strengthen the glute med?
So.
In standing with isometric and core.
Yeah, so Carlos showed us Captain Morgan. So that
Captain
is.
Morgan.
I need a flat wall for it, whatever.
Pretend we have a flat
Hip
wall.
in 90,
Yeah.
and then you're pressing your hip into the wall.
Very
It's
good.
like
So
you're
I
trying.
do it this way, and Carlos definitely knows more than me. I do it this way.
Just out there.
Same thing.
Can
I
you
just
move the
have to
chair?
like this.
Can you
Instead
move
of
the
like this.
chair?
Yes, you're gonna tell me why I'm wrong, and you're probably right.
I'm not saying you're wrong. I like
Okay.
that way too. What I like about mine is that I'm mimicking the running position, right? You're
Ah,
bringing that
see?
knee up
Yes,
and you're trying to
yes,
mimic
that's-
that running pattern.
When it comes to
activate-
Therex, Carlos knows so much more than me. I like it.
Ooh.
Did I have that on? Was that recorded?
We can delete
Oh.
it. We can cut that. We can cut that.
It's true, I like it. But what's really cool is that we thought of the same exercise.
Yes.
I think that's cool. I just thought of it, I do it one way, he does it the other.
Great minds think alike.
Yes,
Alright,
they do.
so there we
Okay,
have.
and you see why it's core, right? If you try this exercise, your core is engaged. Next, single leg with weight and I want 2 single leg exercise. Did I skip
I thought we were
something?
gonna do ISO with core.
That was iso with core.
No,
No, that was glute med.
that's good.
Oh, but isn't this isometric with core?
Could be.
Glute med, isometric and core.
Totally, I mean.
But we wanna
Alright.
do, hold on.
All right, sorry, my bad,
Okay.
my bad.
We're gonna do, hello, press.
Isometric standing with core.
We standing on one foot to make it glute med.
Sure.
Sure.
So how come all the patients
Sí, sí,
stand?
claro, claro.
All right, good.
So-
Eric is blocking you. I couldn't see it.
It's Eric.
So you gotta stand on the left leg if he's pulling in that direction, right?
Well, we had a progression on the single leg.
But if he's pulling in that direction, now you're stopping internalization by activating your.
Excellent.
Right.
I like it. All right. Now the single leg 1 and 2 with weight and contralateral hand. That
So,
was
we're
single
gonna-
leg squat and single leg deadlift, or is something else?
No, single leg
Come on,
squat.
let's see what you had. What do you have?
We only
Single
had,
leg
like,
number 1 with weight.
We're gonna do running man.
Show us. All right. So it's a single leg.
That's not the one.
That's
What
not,
about
is that really an exercise?
No.
It's gonna be running man with, what do you say, weight on the opposite side, so it's gonna be like the weights here, and then down, and then up,
And you call that what?
running man.
I call it a single leg deadlift.
Yes.
But no, running
You
man
can
sounds
Google it.
cooler.
It's-
Running man
it's-
sounds
Like
cooler.
a Jamaican
Is it-
back.
It's a single leg.
Jamaican.
I like it. What's your other single leg?
Then, I don't know, you guys help me.
Single leg squat?
Single
What do
leg
you
squat
call
is
that?
perfect.
Stargazer?
Maybe.
Okay, so we'll do a stargazer, a single leg squat.
And what
Okay.
we're gonna do.
And the joint moves are the same, just more aggressive, right? Now, I want to see phase 3. What is the patient ready for phase 3?
Garrett has 5 out of 5.
When the patient has 5 out of 5 strength? Okay, so let me see dynamic core stabilization with a physio ball. Watch this, Christy, you're gonna be amazed.
She is not
Oh, that's what you do,
amused.
right? Just sitting on the.
Oh no.
Sitting.
But that, I mean, yeah.
Do a pike, no.
I mean, yeah, good.
Alright, now you put this in the sand.
Wait, a deep, a deep.
Yeah, well, yeah, but this floor is really slippery. It's hard, yeah. Good, I love it. Now, the plyometrics. Low, medium, and high. What are you gonna show us?
So for jump progression, we're just going to do ankle jumps.
Ankle jumps?
We just jump
Right.
the ankle.
Yep, that's a low, what's a medium?
We're going to do stationary split squat jump.
Okay, so it means where the legs do not, and then a high,
High is just the same thing, but you're going to cycle. them.
cycle split squats. Very good. Now, what about hops progression?
So for the hops, we're just going to jump over a little barrier. There's no barrier, but
So, okay.
a little barrier. You're just going to jump
Wait, can I get a picture of you jumping over a low barrier?
Eric, watch
Come on,
out.
Say go, hold on. All right, go.
For Fred.
Especially with those
You guys
shoes.
again?
That hurt my knees.
Nice.
Whew.
Those shoes,
Bend your knees. Whew. Bend your knees, man.
Bend, then.
Do it flat.
No, like,
Do it flat.
never mind, just jump.
I know what you, okay.
Yeah.
Oh,
It
jeez.
never came out. Wait, one more time. My phone to go.
I believe I fly.
Hold on. All right,
Can I
go.
sing his music or is it?
That's also bad.
Also bad?
Yes.
R. Kelly.
Oh,
Whoa, whoa, take it
Oh.
easy.
We
Take
didn't
it
do
easy, take it easy.
that. Yeah, we didn't do that right there.
Oh,
All
yeah.
right, good, that was, and you could say the low, and what's a medium?
Or we just make it higher.
Higher, or,
Or over the table.
yes, you could do that, and, that's fine, or zigzags would be a high. Alright, now, patellar taping. Patellar taping, Carlos is gonna show you how to do a technique. In Blackboard, under the lab, I showed one of my techniques.
Oh.
Carlos will show one of his. You could do either technique for the practical, okay? We're even gonna give you a parting gift of taping. Wow. You can practice. Oh, you're excited, I thought that face was like, oh no, more
No,
stuff.
that's awesome. I learned at my clinic.
Well, now you're gonna learn it right.
I got it.
You translate.
I'm kidding.
Mm.
All right, but before we do the taping, let me just say quickly the modality.
Sorry.
You want to give Easton to control pain to the patella. What are the parameters?
Fremont, comfortable tingling.
Fremont, comfortable tingling. Good. Can I give the play-by-play? So Carlos is using alcohol. Why? Because the body's natural oils and all the fancy stuff that you buy, Kat. Lotions, whatnot, oil dips, whatever you do. Will affect the sticking of the tape. So obviously you want to do the alcohol.
Remove the grease.
Remove all the grease. And if the patient really uses lotions for real, you would tell them it's not going to work. You have to wash it off, otherwise it will stick.
She's really ticklish.
She needs only.
Alright, so you'll take the tape, you'll cut.
Wait, hold on, time out. Is it possible just like, I want a video of just the taping and post it? Can we do that? Oh, can we do that?
Start.
Can we stop?